Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis and in prediabetic individuals. I'm Olga Zahariev, a UK-trained dietitian, currently working at the Division of Pancreatic Diseases at Semmelweis University. My vision is a world where preventable diabetes is prevented, and my mission is to shift health policy towards prevention and to educate patients. I will use different approaches to explore diabetes prevention. The first project aims to identify patients at risk of developing diabetes after acute pancreatitis. The second project is an interventional study exploring the effect of dietary fat content on pancreatitis recurrence and endocrine insufficiency. The final project is a meta-analysis investigating various diet and exercise interventions on preventing diabetes in the general population. So the first project is identifying patients at risk of developing diabetes following acute pancreatitis. The manuscript writing is in its early stages, and we are aiming to submit to the Lancet Diabetes and Endocrinology. Diabetes mellitus is the 9th leading cause of death globally, and it has a huge economic burden on society. Moreover, approximately 23% of the patients go on to develop diabetes within the first 5 years after acute pancreatitis. This number can be as high as 60% for abnormal glucose tolerance. However, there is a gap in knowledge regarding diabetes mellitus formation following acute pancreatitis and patient management. Therefore, as a first step, my project aims to identify patients at risk of developing diabetes following pancreatitis. So the patients are acute pancreatitis patients without diabetes at the point of discharge from hospital. We compare various biomarkers to their absence, such as severity, etiology, necrosis, and obesity. We hypothesize that diabetes develops significantly more frequently after acute pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. Systematic search has been carried out in October, identifying nearly 12,600 records. After full text selection, we have been left with 50 studies to be included. We have results for all the outcomes that we are aiming to explore. And on the first plot, you see the association between severity and the development of diabetes and abnormal glucose tolerance. You see here the pooled odds ratios, and a value over 1 indicates an increased odds of developing diabetes or abnormal glucose tolerance following pancreatitis, and that this would be increased in the exposed group. The exposed group is indicated in the first column, and the comparator is in the second one. You can also notice that the outcome, we have explored 2 of them, diabetes and abnormal glucose tolerance. Abnormal glucose tolerance is an umbrella term, which is not just diabetes, but prediabetes as well. This was important because some studies have not reported diabetes separately, but included both of the entities. So this slide shows for us that compared to mild, having severe or moderate disease progression is associated with an increased odds of developing diabetes or abnormal glucose tolerance following pancreatitis. Moreover, you can notice when you compare diabetes and abnormal glucose tolerance to each other that the effect is more pronounced for abnormal glucose tolerance than to diabetes. Figure 2 shows the association between etiology and development of new onset abnormal glucose tolerance. You can notice that hypertriglyceridemia is associated with a 3.33 times higher odds of developing diabetes following pancreatitis. However, this was not statistically significant, which is likely due to the small number of studies included and the participants. However, alcoholic etiology is associated with a significantly increased odds of developing diabetes, and this is likely explained by the fact that many of the patients develop chronic pancreatitis later on and also struggle to quit drinking when the first episode happens. On the other hand, biliary and idiopathic etiology is associated with a lower risk of developing diabetes following acute pancreatitis. Figure 3 shows the association between local complications, and it tells us that necrosis and pseudocyst formation is associated with an increased odds. However, recurrent pancreatitis have not been associated with diabetes later on. Figure 4 shows that comorbidities or demographic factors have not been found to significantly impact on diabetes development later on either. So as a summary, we can conclude that our meta-analysis found from these studies that severity, moderately severe disease, alcoholic etiology, necrosis, and pseudocyst formation increase the odds of developing diabetes or abnormal glucose tolerance. However, biliary and idiopathic etiology shows to decrease the odds, and we have also found that some factors have no effect on this relationship. The study has been supported by robust scientific methodology, and some of the pools included have had patients as participant size as large as nearly 66,000. However, the studies included have used heterogeneous definitions for the outcomes. While some of them use laboratory markers with exact cutoff points, some of them included only patients collected data only by medication prescription or self-reported data. Also, they have used various follow-up time regarding the outcome, and that would make a big difference compared to checking it at 1 year or at 12-year time. Therefore, we have included subgroup analysis wherever we were able to. Current guidelines advise to follow up patients for diabetes mellitus formation and prediabetes following pancreatitis. Our study would add and enhance these advice by advising on more frequent follow-up for the following populations, such as having severe disease or alcoholic etiology or having local complications. Future research should focus on developing preventative strategies after acute pancreatitis. The second project is an interventional study exploring the effect of dietary fat content on pancreatitis recurrence and endocrine insufficiency. I'm lucky enough to be co-coordinator on this project. The rationale behind it is that 35% of patients go on to develop recurrent pancreatitis, and many also progress to chronic pancreatitis. Alcoholic etiology and biliary etiology has a solution to prevent further recurrences, such as alcoholic abstinence and also cholecystectomy. However, idiopathic etiology patients are often advised to maintain a low-fat diet without actual evidence behind it. Therefore, to fill this gap, we are aiming to conduct a randomized control trial to test the effect of dietary fat reduction following acute pancreatitis. They would have 2 arms this study. One of them would be instructed to consume 15% fat compared to the 30% fat group. We would follow them up for 2 years and have contact with them 6 times. 5 of these times we would also have dietary intervention with them and advise the patients. As a co-author and dietitian, I was given the task to develop the intervention and all the resources for the patients to enable them to keep the diet. We have developed weekly meal plans, recipe booklets, shopping lists, food composition data, advice on cooking techniques, and if they can't cook at home, how to go around that, how to read the labels. And we have also taken into account how to collect good evidence data, because 3-day food diary is the gold standard method, but patients need to be taught how to collect that. I'm happy to announce we have enrolled 2 participants so far. So not 28 as my previous colleague, but we are so happy with these 2 already. And the final and the last project is another meta-analysis which investigates the effectiveness of diet and exercise interventions on preventing or delaying diabetes in the general population. We have mentioned that it's a huge health and economic burden on society. It also takes years to develop diabetes and preceded by prediabetes. At this stage, lifestyle interventions have been found to be able to reverse the disease. However, there's a lack of guidance on the most effective lifestyle intervention. Therefore, the aim is to identify what is the most effective lifestyle intervention. The population would be pre-diabetic or insulin-resistant adults, and we compare various diet and exercise interventions. The outcome of interest is new onset diabetes, and we believe that there will be a difference between various diet efficacy. This is important because nowadays there is so much conflicting data out there, and people believe that they become nutritional experts just after having read a couple of articles. So having evidence-based proper guidance to tell them which one is the most effective would ensure patient safety. Preliminary research has found several records, and we have also found some meta-analysis already in the subject. However, none of them have separated out the different diets. They have all pulled them together, and that's what we would be aiming to add to the literature. So all in all, my PhD will identify people at risk of diabetes after acute pancreatitis, will determine if dietary fat content affects acute pancreatitis recurrence, progression to chronic pancreatitis, and endocrine insufficiency. It will also enhance the understanding of the efficacy of various lifestyle and diet interventions preventing diabetes. Thank you for your attention, and I would like to close the presentation with a quote from Thomas Edison. "The doctor of the future will interest his patients in the care of the human frame. Diet, and in the cause and prevention of disease. Thank you very much.
Congratulations, it was a very nice presentation. My question is, even in IBD patients, the drug adherence might cause sometimes a problem. So how would you, or how do you think that your nice to patients and the ongoing ones would follow your strict diet restriction, 50% as it is, or 30%?
I agree. It's going to be a very tricky one, and that's why we have tried to make the education material as simple as possible, but still enough detail for them. And then the other part would be that initially it was planned to have only contact with them 2 times initially and at 1 year. But based on patient feedback, there was a pilot part, and they were asking like, oh, can we have it more frequently? So now we are actually going to give them advice and meet with them for every 3 months for the first 3 times, and then at every 6 months. So it will give them enough contact with us, and also there will be a phone number that they can call, hopefully not on the weekends, but there will be a number for them. And also the other important part is they might not follow the diet, but having a look at their dietary intake, we'll be able to see, okay, at least they have dropped this much, so we'll be able to kind of make another analysis, not just based on the groups, but also based on what was the actual difference between where they started from and what they are eating.
Hope so.
Thank you.
Okay, next question. Daniel.
Thank you for your excellent presentation. I've got a question regarding your first project. Based on your data, we can see that one session of a moderate acute pancreatitis leads to an abnormal glucose tolerance, but we can't say it on the recurrent acute pancreatitis. Why is it so, and do you have any idea about it?
Thank you for the question. It has baffled us as well. We were expecting to see that recurrent pancreatitis would be associated with an increased odds of developing diabetes as well. I believe that it has been probably one of the studies that included large number of patients. However, they were one of those studies where they only included codes for diabetes. They haven't actually tested patients. So they had a giant, like 50,000 patients involved or something like that. But because it was not so stringent, the methodology in it, I believe that that has diluted the results. So I hope that when there will be even more studies, it will actually bring out the results properly. Thank you.
Thank you, Olga, for your presentation. I have a question regarding your first project. So your population, acute pancreatitis, without diabetes, and they got discharged.
Yes.
And you're assessing like different biomarkers. How do you have any missing data? How do you want to make sure all the patients gonna come back? Do you have a follow-up time, for example, to check if they have diabetes later or not?
No, so the first project is a meta-analysis.
Yeah.
So some of the studies that have been included were, some have called the patients back and were assessing it, but as I said, the time varies. 3 months, 1 year, 6 years, it varies.
But all the patients came back?
All the patients came back,
okay.
But there was one study where they have only included patients that came back to the hospital, because that was a big nationwide registry data, so they could only get data that they have been admitted into hospital again.
Yeah. Okay.
That's the one that the recurrence was skewed by, I believe.
So thank you very much. I wanted to ask whether you thought about checking the data with these patients, like in your study, whether they actually follow the diet. Do you think that these given follow-up times would be enough, or would they be given like week-to-week or month-to-month recommendations or checkups? You know, because the longer the time goes, the more unreliable the data gets. So that's my question.
I understand that completely. So we have the software to analyze the data, and we are planning to analyze it before they come back for the next checkup. So now we have the baseline, we'll assess that, and then when they come back, we can input the data. But that will take some time, so they won't get it immediately on the day, the feedback. We will still have a quick look at it and assess it based on our knowledge, but the specific grams we will be only able to calculate and say after the software has done the job. Thank you.
Yeah, one last question.
Thank you for your nice presentation. And I would like to ask regarding your second project, while you wrote your recommendations for this diet, have you taken into consideration what if the patient got a very low income?
I believe it can be worked around it. They would have to just choose certain ways, like some of the not necessarily healthy stuff can be actually quite expensive if they take it just quickly and off the shop. So actually giving them like proper food advice from whole grains like rice, buckwheat, quinoa, not quinoa, okay, so that's going over the, but millet, so there are other options that they could choose. Choosing whole grain will be quite cheap. Thank you.